Welcome to the Oxygen Alliance YouTube channel, where we bring you videos on installation, maintenance, and various trainings on oxygen equipment and devices. If you have comments and or questions, drop them in the comment section below or write to us, info@oxygenalliance.org. Remember to like our videos, subscribe to our channel, and hit the notification bell.
Welcome everyone to this webinar, and thank you for joining us. My name is Roy Gaembe. I'm the Biomedical lead for the Oxygen Alliance, and today I'm excited to be your host. So I'm joining this call from Piringu, Malawi, and I would love to know where everyone else is joining from. So please flood the chat with your name and your country that you're joining from. All right, so for today's session, we'll be having a panel discussion on bridging the procurement gap, ensuring access to spare parts and sustainable service support for medical equipment. So yeah, you may agree with me that we have all experienced breakdowns for medical equipment as biomedical engineers or as technicians. So some usually last a long time, not because the problem is complex for the equipment, but maybe because the spares are difficult to find, or maybe the procurement process is taking too long, or something is not just in place. So these are the gaps that stand in the way of keeping our medical equipment running. So today, our panel brings together professionals. We have 3 panelists with extensive experience in this area, and they will unpack these challenges and share ideas on how we can close these gaps. So yeah, today we have Dr. Raphael, Mr. Chimwemwe, Tiyesi, and Mr. Emmanuel, who will introduce themselves briefly in a moment, but I'm really looking forward to learning from their insights and from you as well, the audience, because we need you to participate as well in the chat and even in the comments that we'll be making. So please feel free to participate throughout the session by sharing your thoughts or questions in the chat. At some points, I also invite a few of you to share your comments, or if you have any questions directed to the panel. Yeah, so with that said, I would like at this point to give a chance to the panelists to introduce themselves before we begin our discussion. So I would give the floor to Dr. Piringu to briefly introduce himself, and yeah, the next panelists will also introduce themselves as well. Over to you, Dr. Piringu.
Good afternoon from Malawi, Zomba. My name is Raphael Lawrence Piringu, and I'm the Director General for Zomba Mental Hospital. Previously, I've worked in 6 districts as a Director of Health and Social Services. And again, I've worked for 4.5 years in 2 districts as a District Commissioner. And I've been involved in procurement at local and national level, and again with the Department of Procurement. Meanwhile, I'm based in Zomba. The Zomba is the first capital city of Malawi. I'll be one of the panelists this afternoon. Thank you so much.
Dr. Piringu, I would also like to request that you also turn your camera on so that people might see you. And also, as you will be interacting during this panel discussion, you'll be required to turn on your camera. Thank you.
Okay, I will do that.
Thank you so much. Over to you, Mr. Tiyesi.
Oh, I was speaking on mute. Thank you so much, Lloyd, for the opportunity first. And for the introductions, my name is Chimwemwe Tiyesi. I work as a program manager for the OpenO2 program. Some know it as an initiative where we are maintaining oxygen concentrators in different hospitals across Malawi. I work as a program manager, as I said, for the OpenO2, which is under the Global Health Informatics Institute. So over to you, Lloyd.
Thank you so much, Mr. Tiyesi. I would also call Mr. Emmanuel to introduce himself as well.
Thank you so much, Mr. Gaembe, for this wonderful opportunity that you presented unto me to be part of this meeting and be able to share. My name is Lungu Emmanuel, a biomedical engineering technologist at Luampa District Health Office in one of the districts in Western Province of Zambia.
All right. Thank you so much, Manuel. Please also remember to turn on your camera.
And unfortunately, the gadget that I'm using, the camera isn't working.
All right. Thank you so much. So without wasting much of the time, I would like to go through the objectives of this panel discussion. So these are our panelists. Of course, we were supposed to have Mr. George as well, but due to other circumstances, he wasn't able to attend. Instead, we are glad that we have Mr. Emmanuel around. All right. So for the objectives of this panel discussions, we will first examine the root causes of procurement and supply chain challenges that are affecting biomedical equipment functionality. We're going to highlight or point out the realistic or workable ideas that's practical solutions to improve access to spares and technical service support. The panelists will share their practical experience on salvaging and using of spare parts without compromising safety, and to discuss the strategies for maintaining a reliable spare parts inventory. And on top of that, I will highlight some of the approaches to justify and secure maintenance budgets, and also promote collaboration between payments, procurement teams, suppliers, and policymakers. So with this discussion objective set in place, I would like to start by posing a question to the panelists. So my first question is on the procurement gaps. So, Mr. Emmanuel, what are the most critical procurement gaps affecting equipment uptime? Or maybe to put it simply, which weaknesses or problems in the procurement processes are most responsible for medical equipment downtime for long periods of time? Over to you.
Thank you so much for that. In my case, the most challenging or pressing issue that has been affecting the medical equipment uptime, both at district level as well as the health facility level, maybe just to highlight more on the role that I play, where I am stationed here. I am stationed at the district health office that oversees the overall health delivery services of the entire, where I service about 16 health facilities within the district, inclusive of a mini hospital as well as the district hospital in our regard, which is a mission hospital. So most of the critical aspects that reduces the medical equipment uptime, in my case, number one, is the issue to do with the procurement. In my case, no biomedical engineering personnel has ever been involved or engaged in any procurement committee, where issues to do with the well-being or the welfare of medical equipment is concerned, to do with the acquisition, procurement of spare parts, and other consumables. That has really been a challenge in a way that whatever discussions that are made in that committee, the biomed is not involved. And the same committee, that's a platform where resources to do with the spare parts, procurement, consumables, procurement are usually tackled to just highlight what is needed at that particular moment to bridge the gaps in terms of factors that affect medical equipment uptime. I submit here.
You can raise your hand and I will point out to you. All right. Yes, Chimwemwe. You can speak.
Yeah, thank you so much, Lloyd. I just wanted to add to what Engineer Emmanuel said. One other thing, of course, we should not just look at the procurement side, but as biomedical engineers and technicians, what is our role? And of course, this goes deeper to the systems level. We don't have, in most hospitals, proper forecasting systems in place just to know what equipment is available, what is running low, what needs to be ordered. So this is another area that mainly affect procurement. People just work in a proactive manner. There's a problem, or maybe a budget is out. They've called for people to submit their budgets from their departments, and people just write what they want without having any forecasting system or any way of tracking the inventory system on whatever that they want to procure. So I just wanted to bring that and add that to what Engineer Manuel said. Thank you.
All right. Thank you so much, Chimwemwe. I see Dr. Piringu, you also have please you can unmute yourself and speak.
Thank you very much. On the gaps, just to add from the other presenters, in procurement, it's a process. It's a big process whereby you need to start with a situation analysis, whereby now you identify your issues, your needs. So usually, like in Malawi, most of the engineering departments, they lack or there's inadequate planning on their needs. Some because of what my friends have said to say maybe they are not allocated funds or whatever. So people, they are demoralized. But with funding or no funding, in any department, you are supposed to have your needs. So in procurement, when people are asked to say, like in my site where I am, Zomba Mental Hospital, the past 2 years, when I take the technician to say, let's go for planning, usually he doesn't know what he wants. But when you are operating, so now you know, no, we need an aesthetic machine. Like now, we are having issue of the breakdown of the ports. I was reminding the engineer to say, you have been repairing these ports, but now let's now put in your plan that in the next financial year in April, you should plan to procure. So it starts with the planning. If you don't have the planning and you prioritize on equipment which you want, there is that challenge which we are meeting. And again, when you are prioritizing the equipment, at least an engineer should tentatively know the price, the cost. So sometimes maybe internationally the prices are changing, whatever. But in case somebody comes to say, how much do you want for us to support you? So again, the issue of pricing is another gap, because people take maybe 2 months or maybe over a month. Me as a director, still waiting. And sometimes I just come in to say, I'll do this on my own. It's like the coordination among the biomedical engineers, according to my experience, is not strong. If it is strong, maybe on this platform, if you guys, you'll be coordinating maybe in Africa, you'll be even knowing how much this is costing in South Africa or how much it's costing in Uganda, whatever. And again, which brand is the best? Because me as a doctor, I just use those things, and I'm seeing again that again as a gap. And another thing is the management team tends to have no appetite of including the engineers. That's the result of what my friend has said. They're not included now in the procurement team. It's like he's not talking, he's not telling us anything. So they are not included. So when they are not included, the gap is now when you want to buy that equipment using the specs, to find the specs, real specs for doctors, whatever, to use that machine. So again, in the procurement, it's again an issue. So maybe that's, I stop there. maybe, yeah, thank you.
All right, thank you so much, Dr. Piringu. I've seen another hand, but of course, on the next question that I wanted to ask is on the barriers to timely procurement of spare parts. So I think Dr. Piringu, you also highlighted some of the things. I'll just give this moment to Alan, who has raised their hand, just to make his comments as well. So just briefly, under a minute, and we can look at the next point as well on how the local sourcing of food procurement can help. Yeah, over to you, Alan.
All right. Thank you so much, moderator, for this opportunity. I am Alan Jidoi from Uganda. Most of these problems and hindrances in procurement, I think, are across the globe, especially for us in Africa. Now, most of the hospitals, especially for us in Africa, most times I think the biomedical field being a new field is that they do not include us on the budget. So in most facilities, you will find we have no spares budget at all. So they will they will make a budget for pharmaceuticals, laboratory supplies. By the end of the day, they forget biomedical in it. And some of them include, we go as far as biomeds. Now this is on our end that we do not have a spares. Perhaps you do not know what you need to have in a spares inventory as a biomed, which is one of the big hindrances. And then also my colleagues have spoken about the long bureaucracies that is perhaps common in any of our systems, especially pharma systems that we follow. Now, the biggest that I have observed, especially for us in Africa, is the donated items. We tend to receive these donated items, but at the end of the day, we do not evaluate spare-wise what we need to have as a condition for us to receive this. Because you receive probably an anesthesia machine, but then it could be probably have a part that is likely to fail and the hospital cannot manage it. So the hospital, as we receive donations, and we need to ask ourselves, and we need also ask the hospital, can it be able to support the spares for this machine? Can it handle its maintenance? Can it handle all these other things? So when they also put a budget for funds for these donated items, I think we can reduce this procurement burden and to a manageable level. Then another question or another thing we need to put in consideration is the source of these spares. Now, most of us are having equipment in our facilities, but we do not know where to source the spares. Okay, you put in a requisition for a spare, and then perhaps you make research on the price. The money will be available, but you do not know where to source it from. So I think it is very important for us to network and probably help one another. How can we source these spares? What would be the price in the other? Where do these people normally source it from? In that way, we can reduce the gap in procurement. Thank you so much, Mr. Speaker.
All right, thank you so much, Alan, for those highlights. We have listened a lot from you. So now I just want to know about this question on local sourcing. Maybe Dr. Big, maybe you would highlight more on this. So in your experience, do you think like buying medical equipment or spare parts locally helps? Or maybe food procurement, that is combining purchase efforts. I think you also highlighted on this. I just want to hear more from your thoughts about this.
Okay, I was seeing somebody raising a hand. Yeah, to my experience, using equipment locally, that's the best way. That's the best way because it is cheaper, and anytime you want the spare parts, you do it well without having any problems. I have the experience from Alan in Uganda. I think our friends, they are doing well because the biomedical engineers in there, they've got their own companies. And again, they can communicate with the hospitals and to ask for their needs. And within that, they are able even to tell them the specs which they want. and immediately they start supplying to hospitals, and that's the best. But as Alan has said, if we want to import from other countries, it is expensive, but the main problem is now the issue of the spare parts, if you want them. If you are procuring from abroad, outside your country, you make sure that the spare parts are there. So again, that's the issue of the importing somewhere. So to me, I prefer, if we have local things, and again, we have the specific companies within our countries, and we are able even to meet them and tell them our specs and our needs, the issue of the spare parts cannot be there. And even we can reduce costs. But for us to do that, we need to standardize our equipment because of the issue of the donation. For example, the oxygen concentrator, there are a lot of brands. So as engineers, you need again to standardize, to say which brands are the best. And from there, we start to import those brands which we'll be using. And then it will be easier for us to be having now the spare parts within our country. For example, if we have maybe Siemens, an engineer who has finished his work, has got enough capacity, financial muscle, can open even a shop on the same equipment and the spare parts. So sourcing locally is cheaper. And again, this one, you coordinate easily. And even the training institutions may find it simpler to practice servicing these equipments, which are locally available within our country. But maybe the bureaucracy, the markets outside in Europe, they may start maybe hating us to say we are not buying from them. But that's what, again, I prefer. And this is my experience. Local things are very good when they are properly managed within the country. Thank you.
All right, thank you so much. I've seen two hands, Mire and Chimwemwe. So I will strictly give you a minute each so that you express your comments as well. So Wire, over to you. You have 1 minute.
Thank you very much, guys. I just want to come back to the previous point, and I think it links to the second point on your agenda that you've got on the screen, is that the importance of specifications when procuring product. I always say your product that you will receive in whatever country in Africa, the quality will depend on the quality of the specification that you've put out before you procure the product. And part of that, a specification needs to be also the topic of spare parts availability, etc. So if you put your specifications in place, the quality of product that you will receive will be much better, because you know you are getting what you asked for. So I just wanted to bring that to the table as well. Thank you very much.
Right, thank you so much, Will, for that contribution. Chimwemwe, over to you.
All right. Thank you so much, Lloyd. I just wanted to speak to this issue of local sourcing. So when we are talking about local sourcing, it's mostly about local traders having these spare parts that we want to buy or procure. But there are challenges. Many local traders are not incentivized enough to source medical equipment to sell them. On top of that, we have a lot of forex issues. I think it's the same with many low and middle income countries, which now becomes a challenge for them. So I just wanted to point that there is still an issue with this local sourcing issue, unless there are clear policies and also willingness from government agencies to enable these local traders, give them breathing space like taxes and everything, so that they can bring in this medical equipment, spare parts, so that we can easily buy and source them from Malawi. I just wanted to point to that. I think at some point I'm going to tackle what Willie just said about putting specifications. I'm sure that many engineers do put specifications of what they want, but then the Chinese became very, very clever at just meeting the minimum specifications then they provide you with the equipment, or you can buy the spare parts, and then you're worried about the quality and everything. So yeah, those are the 2 points that I wanted to point out. Yeah.
All right, thank you so much. Talk, I've seen your best. Yeah, you can speak, but you have a very limited time, immediate, less than a minute.
Yeah, okay. I was just trying to say on the issue of Forex, I think it's the challenge is only Malawi. But if you go to our friends, it's not an issue. So in the absence of Forex, as you have said, I think that is the procurement locally. As I've said, the example of Uganda is easier. And again, you give the specs. It's the buyers who goes to the engineer to say, these are the specs of the machines we need in our hospitals. You are empowering the engineers, and again, you are even strengthening your own country. But the Malawi issue is another scenario. However, within the local traders, there are no tight policies. Like Zomba Mental Hospital, we have used the same local traders with the specs we wanted to procure us the anesthetic machine, and now they are bringing us a 50 kilogram heavy washing machine. So that even the local traders, we are not going to the India. So to me, I still strongly prefer the local issues, but now following the other friend to be careful when doing that, following the specs, and again with the good policies in the country, the issues of Forex and others, if they are in place, that is a good way to go. Thank you.
All right, thank you so much. Thank you. Remember, you can also be commenting in the chat. Anyone, you can comment in the chat on the discussion that we are having. I will also would like to hear your views from there as well. So we have highlighted several challenges in the procurement process, and now I would like to learn from the experiences from our panelists. So right now, let me focus on Mr. Chimwemwe. I am interested in your experience with salvaging spare parts. So from your perspective, is this a practical and workable approach to help address some of these challenges in accessing spare parts?
All right. Thank you so much, Lloyd. I would start by saying that the most practical approach would be to managing spare parts for medical equipment is what Dr. Piringu said, standardizing and limiting the number of equipment models in use, and coupled with having a very robust and excellent procurement and inventory management system. Why am I saying this? If we have, and again, the issue of local trading, if we are to empower the local traders to deal into this medical equipment spare parts, this would be what you call the most practical approach. So why am I saying this? The reason is when hospitals have, let's say, just 2 or 3 models of oxygen concentrators or suction machines or any other machine that you may have, anesthesia machines, it becomes so easier to forecast spare parts needs. You know what exactly you have and what's left in the inventory management system that you may have. Even a paper-based one can work for your system where you have a few models of medical equipment. But in many cases, we know that this is not possible. So in absence of all this, in absence of standardization, it's where the salvaging of spare parts becomes a very necessary and also a practical approach, because we know that there are many challenges with the supply chain disruption, the funding and everything. So I will go and explain what OpenO2 has done in this regard, as we've been maintaining oxygen concentrators in over 92 days across Malawi, assessing and maintaining over 2,500 oxygen concentrators for Ministry of Health. And there are so many advantages of this process where we're saying salvaging equipment. So how do you do this salvaging? One, you need to make sure that whatever you are trying to get some parts from, either it be a decommissioned equipment or you are getting from something that's not, you make sure that you have tested, inspected, and make sure that this part that you are getting is actually working, specifically the electronic components, sensors and everything. You need to make sure that whatever you're getting is also compatible. You, like for example, you're getting you're salvaging parts from an oxygen concentrator, from one oxygen concentrator to another. It's very easy and simple if you're doing that from same make and also same models. But there are other situations where you want to get a part from another concentrator that is totally different. You need to make sure that that part that you're getting works within the same range, maybe doesn't need any modification. You need to be careful with sensors and everything. You may get an oxygen sensor from one model to another, but then you don't actually know what calibrations were done inside that, and you may get issues of control board. You have different timings that are there. I'm sure the engineering friends here understand what I'm saying. You can just get one board from one acid concentrator to another if they have different flow liters. So those are some of the issues that you need to pay attention, right? So going to give an example of how this scavenging system works for the OpenO2. As I said, we are maintaining oxygen concentrators we've been maintaining in over 92 district hospitals. When we had just started, we did not have a lot of spare parts. We could just go there, look what we have there. If we see that there are 2 oxygen concentrators or 3, we could lace 2 out of 3 concentrators. At least you have something there that you can use. To talk to that, there is another way of doing things. Like, let's say for oxygen concentrator compressors, there are service kits there. You have over 80 different models of oxygen concentrators with different compressors inside. But what you find out at the end of the day, that these compressors are coming from a small pool of manufacturers, and they have similar performance capabilities if they are delivering the same flow liters. It's not for every compressor that's delivering same flow liter, but for many, there are similarities, even down to the compressor kits that they have. So what you need to do is to have flow data. You test this and see which models are actually working, which one can you interchange. You can look at the performance chart for compressors and everything, and you are getting, if you see that this is within range, you can actually swap those parts. For example, we are maintaining over 80 different models, as I've said, but we only stock about 8 different types of service kits for compressors, which we are able to fix over 90% of all the oxygen concentrators that we face. So having field data coupled with testing, you will be in a position that you will know that we can interchange this on this. For oxygen concentrators, again, because I've worked so much in this area, that's why I'm giving these examples. There are different parts in there that you can actually swap. Come to the issue of zeolite materials, which is a very big issue with oxygen concentrators and also oxygen plants, but I'll talk specifically to oxygen concentrators, right? There are different configuration of the sieve beds that contains the zeolite in different oxygen concentrators. And it's very hard for a hospital or biomedical engineering unit at a hospital to have an inventory of all these different sizes of sieve beds. But we know that for most oxygen concentrators, they use 2 different types of zeolite. You can buy zeolite in bulk. You buy zeolite in bulk, you just replace the zeolite material in the canisters you are able to go. So this issue about scavenging and also going an extra mile in terms of the scavenging and look at the data from what you have in the hospital, which works in similar ways. What can I learn from this? Do we have data? Have we done the inspection? If yes, and everything is controlled, you have procedures, you clearly label whatever spare part that you have scavenged and used in another concentrator, and you're tracking that, you should be able to go and also reselect, and at least you have a breathing space and you have control back as a biomedical engineer instead of waiting for these bureaucratic processes that we have in hospitals. So I just wanted to bring that to your attention. Or to top on that, actually, we need to also have innovation. Here at OpenO2, like for one of the consumables for oxygen concentrators, we are actually regenerating. For some parts, we actually fabricate. If you're looking at blackheads or some non-critical parts of the machines, you can actually fabricate as engineers using the knowledge that we learned in school and actually bring it here, which will actually save the money, and the money can be used for other purposes at the hospital and actually improving service delivery overall for a hospital. So with these remarks, I think I should give it back to you, Moderator Royd.
All right. Thank you so much, Chimwemwe, for highlighting those things. I think we have learned some things from there that we can actually salvage spare parts from equipment that is very important in turn, trying to resurrect some of the equipment. Yeah, and everything else. And I think you have also tried to cover on the part of tracking and managing these spare parts. So maybe at this point, I would like someone from the audience just to explain how they have done this type of activity. Yeah, if they have ever done. So you can raise your hand if you have any experience on this or how you do it from your side, or any comment or any question that you may have for this. Yes, Dr. Piringu, I've seen you raise your hand.
Yeah, I'm seeing people are not raising. I just wanted, apart from the oxygen concentrators, we can again, for example, the hospital beds. There are some hospital beds, maybe they are broken, and they can be repaired nicely. So they can be fixed, repaired, and again, they can be painted well. And again, you take the same beds, you can take them back into the hospital. Sometimes some of the drug boards, maybe the boxes, whatever, you can even repair them, paint, clean them, and again, take them back in maybe the blood pressure machines. Sometimes it's just the car, which is a problem. You can change it for another car, and again, you fix. But what Chimwemwe has said, a good biomedical engineer, after the equipment have been procured, they need to have an inventory within the department. And again, every room should have again an inventory sheet. And again, within the inventory book, even you write the serial number of every item. Every item has got a serial number. So when you are swapping, definitely you will be now recording that serial number. And once you have fixed the serial number to another equipment, this one now is now totally not in use. Now you put somewhere to say this serial number now is ready for board off, or maybe its date will not be used. So again, you again summarize all those serial numbers for those equipment which cannot be used. In case you want to send it to the training institutions, you are again writing this serial number machine to go to Makerere University for maybe training. So somebody can track from your hospital after you have scavenged the equipment, you have changed the spare parts, or maybe you have painted the same bed with a serial number, you replace them. That is a very effective and affordable way and very cheap of using the equipment. That's again, we have been doing at the Zomba Mental Hospital as one of the examples, apart from the oxygen concentrators. Thank you so much.
All right, thank you so much, Doctor, for that additional input. So if there is anyone who would like to share his or her experience, you can, or you can just type in the chat. So I will give you a minute just to share your experience as well. Yeah, you have raised your hand. Please proceed and mute yourself and speak.
Thank you. Yeah, just a very short comment on that. I think in our experience, when we get spare parts from countries across the world almost for various items. But what we do in terms of our suppliers, we do a very, very in-depth check on them to ensure that they are reputable and that we know that when we do have a need for spare parts, we are able to get them. So I think very important for us is to ensure that we procure from the right supplier and they could be anywhere in the world. They could be in South Africa, which is in our case where we are based, always a good place to procure from because we are close to the rest of Africa. But we have, we get equipment, like I say, from all over. So the point I'm trying to make is just to make sure that when you procure a hospital bed, for example, that you procure it from a quality supplier that you know that you can rely on. Thank you very much.
All right. Thank you so much, Willie, for that comment. I would like also to give a chance to Alan to comment. Exactly. Let's start 1 minute comment on this as well.
All right, thank you so much. So in my country, what we normally do, we do the same thing other speakers have spoken about. You have a same model of an equipment, one which is functional, one which is faulty. You could pick out something that is useful. That is if it's of the same model. But sometimes this model can be compatible with the other model. You can pick a part from there. But one thing that I see that we make as biomed a mistake is that we do not label that we picked this, maybe this part from this machine, and therefore we shall just leave that machine where we picked that spare part from, and we just leave it there and not labeled anything. So perhaps if the next person has to track what is missing in this machine and maybe trying to troubleshoot why it's not functional, it is really a mess and they cannot do it. And then we have equipment that are donated to us. This equipment can be coming from either Europe, USA, things like that. So most of these equipment that they donate are refurbished. And most times that you're gonna find out that you cannot get that kind of spare anywhere. So what we do is to keep in touch with the donors, because the donors are the people that donate those kind of equipment also know places where they can source the same spares from. So probably you as a biomedical engineer, you will do your technical assessment and maybe assess that this spare part XYZ is having issues and make a technical report, and then report to your superiors. They can see whether they can source that part locally, that's if it's available, or they can revert back to the donors and communicate how best they can, how best they can get that kind of spare and have it sent to you. So that's how we normally source for some of those spares. Thank you.
All right. Thank you so much for that insight, Mr. Alan. The next question that I have to the panelists is how can AMEs influence procurement and ensure technical input is respected? Mr. Emmanuel, I would also love to have your input on this as well.
Thank you, Mohamed. To start with, biomedical engineers can influence procurement and be able to input the technical aspects in terms of procurement of spare parts for medical equipment. The first thing that I would highlight on this aspect is the issue of respect itself. Most of biomedical engineers in our setup, they are not respected. I'm saying this because you might find that there is no proper structure and sanity when it comes to the field of biomedical engineering. For it being a new field in most of our countries, you might find a scenario whereby a biomedical engineer is just considered to be someone who fixes medical equipment and devices. And on the other hand, biomedical engineers are considered to be a jack of all trades in such a way that management perceive biomedical engineers to be some sort of a general worker in such a way that he or she, being a biomedical engineer, they can be assigned any other task away from medical equipment perspective, where they will say there's a leakage on a tap, which a biomedical engineer is responsible to fix. Maybe there's a toilet that has a leak somewhere. They consider it all to be done by biomedical engineer devices. They cannot take part in technical input, such as advising on the technical specifications, generic specifications of a device or medical equipment that has to be procured by the hospital. But as that said, on the other hand, biomedical engineers can influence procurement and ensure technical inputs at all levels of healthcare delivery, in making sure that, if at all, biomedical engineers are included in committees such as the Medical Equipment Management Committee, the Procurement Committee, as well as the Receiving Committee of what has been procured. Biomedical engineers can contribute tremendously to the procurement processes of spare parts in regards to medical equipment by participating in technical drafting of all medical equipment related issues, tenders, and maintenance, such as budgeting of spare parts, and as well as identifying the need that is there at that particular point in terms of procurement plan. Biomedical engineers can also be able to validate, after doing a thoroughly feasible analysis on what is needed on a certain equipment or device, and also prioritizing the major parts that usually break down and also reduce the medical equipment uptime. This also can be done by making sure that for the procurement process to be done, looking at the procurement processes and bureaucracy that we have in our country.
All right. Thank you so much, Mr. Emmanuel, for that. I would like to go to the next section. Yes, I've seen your hand, Alan, already. So I just want, first of all, for Dr. Piringu would also provide insights to justify your maintenance budgets. So how can BME teams build a strong?
Okay, thank you. It's because of time, I'll just maybe summarizing everything. First of all, you guys as biomedical engineers, you need to be known by people out there. How? You need to have an association where you are working like a team in countries. Secondly, at a working place, management team should know how you are working. After repairing something, or maybe you want to unique something, you're supposed to write a report and make sure you present to the director of that institution. Most of the times, we are seeing engineers in some hospitals, they're absent from themselves, they're not there. Sometimes they have done a very good job, they don't write reports. Sometimes when there are other gaps, they don't even give suggestions. In so doing, you are not recognized at all. And again, I can give you the example of Malawi, whereby the engineers who are being hired, they are recruiting nurses, doctors, everywhere. But the engineers, they just said only temporary of them to be recruited for a year. No one said anything in terms of the engineers, and no one suggested anything to the government. It took myself, because I value and recognize the engineer. And I even say, if the engineers can just boycott their work in a country like Uganda for just 2 days, the whole country can just collapse. I always call Uganda. I visited there. I'm seeing a lot of best practices there, like in Uganda. Their association is just very vibrant, and they communicate nicely from the institutions even to the ministry. So in Malawi, it took myself to go to the management team and start now presenting issues of the biomedical engineers until it was now taken on board. But we found that in Ministry of Health of Malawi, there was no establishment anywhere for a biomedical engineer. So it means they could not be recruited in the civil service. By now, we have managed to have the association. We have now managed at least to put in a space now for engineers. Now, all the charm institutions, they have just finalized now putting a recruitment for the spaces for the biomedical engineer to be recruited instead of them hiring. We went to the human resource department. Now they have accepted. So you can see it's somebody who is working on your behalf, but now the engineers themselves are just silent. But the training institutions are just continue training. So once you are recognized and the people, they see you that now you can do this and that, you can bring change. That's when now you can be brought in the system for the procurement. Or sometimes again, an engineer at a hospital can just write to the management team to say, I feel I need to be part of, and you explain and justify. And once you are taken there, you have to participate effectively and write reports and maybe suggestions. And once slowly you see that people can be taken on board and they move forward. But for my facility, since I'm already aware about the engineers, all the equipments we are doing, we are involving the engineers. If our engineer cannot manage, we even hire other engineers from the other hospitals. They help us with the specs, and again, until we procure the equipment. And we are seeing that our equipment at Zomba Mental Hospital are very powerful, durable, and the spare parts are even locally available because we are being supported by the leadership of the biomedical engineers. So to me, I want the issue of planning by the medical engineers to be there, to be presented annually to the management. The issue of a progress report on how things are moving, whether they're not going well, whatever, and put some suggestions. You find that these things will move forward. So it depends with the leadership, and the engineers, they have to focus on their leadership. Sometimes book the director to have a meeting one-to-one so that you convince them. But without biomedical engineers everywhere at every hospital, things will not move well in terms of the equipment. And finally, in the procurement, there is a gap which is across all the African countries. When you are doing procurement, in case this is a new equipment you have never seen, we don't involve the biomedical engineers in terms of capacity building. When we are putting the funding for the equipment, there should be other funding for the training and the orientation of the biomedical engineer. It is not a crime for this biomedical engineer to go to Japan and stay there 3 months to just learn about this equipment they are ordering, so that at least when it goes to their country, they can continue now servicing and teaching others. But what we are seeing in Africa, maybe in Malawi, we find it's a new equipment coming. Once it has got a problem, they have again to call the manufacturer. And the manufacturer can tell you to say, no, I'll be in Sierra Leone, I'll be there and there. Maybe in Christmas, I'll come to your country. And you find the patients are suffering. So this is my contribution to say, as biomedical engineers, we should have associations. Within ourselves, we should unite. And within ourselves, we show the hospital management that we can do this and that. And again, we continue communication and writing reports to our management so that they know that we are there and we are around and we can change everything in terms of equipment at the hospital. Thank you so much.
All right, thank you so much, Dr. Piringu. And thank you so much for those insights. I think we have learned a lot from that. I've seen a hand from Alan, and I've also seen some couple of comments from the chat. I will read them out after Alan has made his comments. But right now, we'd like to hear from the audience anything that you may have, any comments that you may have as well as we close. So over to you, Alan. You can comment. You have any.
Yeah, thank you so much, Lloyd. I think let me first begin from a point raised by my colleague Emmanuel, who was saying that most of the biomeds are not respected, and therefore it really makes them hard to influence procurement decisions. Yeah, that is very true. But one thing I know about respect, we need to gazette our own, should I say, standards as biomeds. One, as a biomed, you have a JD, a job description, which spans from equipment procurement down to maintenance. So you need to understand that your job description is well executed. You know, as a biomed, they're going to call you for a number of things. Here, IT, then plumbing, there's electrical. Please, I think it's time to, when they do that, I understand there are such gaps at the facility, but it is good to also remind your superiors that this is where your job description lies, and therefore you must do everything within your job description such that you save more time for equipment than any other business out there. Then how can biomeds influence procurement? First and foremost, when you enter a facility, the first time you hired, you need to identify what are the gaps in this facility. How can a biomedical engineer be of importance and be an asset at solving some of these gaps? These gaps could be in procurement, these gaps could be in equipment maintenance and all those things. So at the end of the day, while you identify the gaps, you come up with a plan of how you are going to execute and solve some of these plans. If, for example, those facilities are spending a lot of money because of a bad procurement, either in the model of oxygen concentrators or something, you need to point out some of these things in either your monthly or weekly report. As such, the hospital will pick interest in this kind of technical advice you're trying to give. And then you can point out how much it can be able to save by doing some kind of suggestions that you put forward. In such a way, you will be invited to the table to also discuss more. My previous speaker spoke about doing suggestions and doing reports. That is very key. That's Dr. Piringu, and he's mentioned very key points there. Then there's an aspect of how can we biomedical engineers make sure that we handle equipment maintenance. Now, equipment maintenance, in my opinion, it begins from procurement. Once the procurement is a bad procurement, it means that you're going to spend a lot of money in maintenance. So how can we also solve that gap in procurement? One, at least make sure that you struggle as much as possible to be involved in the procurement. And then it is good to coordinate with fellow biomeds and find reputable models to recommend for procurement. You could recommend a model that is not found elsewhere in your country or in your region. So perhaps it might be very hard for you to source spares and also do maintenance and maybe also technical skills in managing the maintenance of that equipment. So you must be involved in the procurement. You know very well that in the facility, the procurement and the finance team will aim at saving costs, while at the same time, they will not mind of the model. So you probably have to explain why, regardless of cost, this is the best model and how it can serve. Let me stop there. Thank you so much.
Thank you so much. Thank you for that contribution. So yeah, we are going towards the end. We just read out some comments that other people have made in the chat. So there's comment from Boyev and Tinadi. He's saying everyone, inventory management, job cuts are the best way to do procurement because you can relate what you require from the codings to get what you want to procure in the next financial year. Yeah, and also there's another comment from Miranda Dixon. So they're saying at Oxygen Collab, we are advocating for governments to establish target service profiles that would set standards for making sure aspects like maintenance are included in and budgeted into the procurement services surrounding oxygen delivery. So they wrote a paper outlining the idea there, and yeah, there's a link that you can go to and read about that paper as well. Or you can email, there's an email that you can also contact if you have any questions about it. Yeah, otherwise, I would like to thank each and everyone who attended this call. It has been really a good experience learning from you and everyone else. Yeah, we ask each other questions and we get responses from here. So yeah, be sure to check it out. It will be posted. Otherwise, thank you so much for attending the webinar. The next webinar will be on the 13th, on the 30th October. Please make sure that you set your calendars and make sure to attend the webinar. Thank you so much. Please have a nice rest of the day. Thank you.
Thank you. Bye-bye.
If you have comments and or questions, drop them in the comment section below or write to us info@oxygenalliance.org. Remember to like our videos, subscribe to our channel and hit the notification bell.